few things I just want to share a bit more about like myopia is about maybe a bit about how to like assess myopia risk in a way. Yeah, so I think that's how like we really want to start off, because with every patient that we are gonna have, if we want to know how we can help them, then we have to be able to know how we want to assess them. Because once we can assess them, then we can kind of like categorize where they lie. Like, are they someone who has like low, medium, or high risk of myopia progression? And from there, then you'll be able to tell how you want to treat them in a way. Okay. But before I go into all that, like, is there any particular maybe questions that you might have about myopia that's lingering on your mind at the moment? Okay. Yeah. As we go on, if you have any questions, yeah, just let me know about it. Yeah. So basically, I'll just go through a bit about like myopia and about the whole if someone has myopia itself, what do we want to look into and all that stuff. Yeah. So as we know, myopia is where they can't see far away, and usually they can see pretty well close up. Now, most of the time, our patients are going to present as like kids. Like, most of them are going to be pretty young in a way, and the issue that they have is that they are not able to see the board clearly in school. There's the most typical one. Sometimes you will get like parents coming in because they see their kids squinting, and the other one that is more frequent is teachers. So teachers in school, they will note that maybe the kid is either not performing as well, or they may be going at the front of the class to try to see, or sometimes those kids who are just not interested. Now, when kids are not interested, we would just want to make sure that it's not really like any other thing that they have, like maybe attention deficit, and it's that instead of like myopia. But usually they will come in for like a full assessment, and then we'll assess them in a way. Now, a question for you would be, when a kid come in and present with myopia, when do you know when to just kind of like trust whatever results that you get in the testing room, versus when do you want to cyclo them usually? Mm. Yeah, so when would you cyclo a kid coming in for myopia? Yeah. Mm. Yep, okay. Yeah. So I would say that usually with kids when they come in, right? If they're currently wearing glasses, then that's not too much of an issue, because we know what's their current myopia level is like. Then we can check and monitor progression. I would be very cautious of those myopes who come in and present on their first time. So their first time ever coming in like for an eye test. But then again, the other consideration would also have to be like, especially if they're like really low myopes, okay, yeah, or if they are like maybe like minus sorry, if they're like 6 years old, so they're really really young, and you just want to make sure that it's not over accommodation. Okay, because if they are over accommodating, you will actually get way more minus out of them, and that's not really true myopia. That's just them living minus a lot in a way. So that's why when you give cyclo, when you cyclo the kids in a way, it really just helps to relax their accommodation so that they won't be able to over accommodate and get too much minus. Okay, yeah, so that's one thing that I find that is very important, especially with much younger kids, and especially those who do not have any prescription glasses here but present with myopia. Okay, now usually once they do get a bit older, so I would say that once they're about 10, 11, 12, right, and especially like above 12 years old, I usually find that they are actually pretty reliable in terms of whether they have myopia or not. And usually by that age, they wouldn't really be lying anymore about wanting to get glasses. Now, with young kids, we know that sometimes they do. The ones that are like 5, 6, 7, yeah. So you have to be very cautious of that, and know that like, okay, when is it really truly myopia, or when is it like they just yeah, when they just want glasses. Now, parents usually have a good idea whether they find that their kids are really struggling or not in a way. And one thing, that I usually get parents to do once they leave the testing room is that, look, one thing you can do with your child is that if you yourself wear glasses and you know that you have like perfect vision with your glasses on, try to read a street sign far away. And then if your child can read the same street sign as you, or at least can read out like the alphabet, if let's say they're really, really young and not that's because that's also very important. Okay. All right. Now let's talk about the important thing, which is what are the questions that you want to usually ask parents when it comes to the child when they come in for myopia assessment. Okay. So I would say that the two very important questions would be about outdoor time and about screen time. Now, the reason why outdoor time is very important is because we want to know how much time they're really spending outside. And we know that generally when the kids are outside, they tend to relax their eyes a bit more because they look further away. All right. So generally, if they spend at least 2 hours outdoors, that's amazing because we know that it means that like they potentially have enough time being outside. So be it either they're doing some exercise or even like just walking to school, all these things are still considered outdoor time in a way. All right. Now, what if got a very interesting one? What if they're reading but they're outdoors? Does that count as outdoor time? Yes or no? Yeah. Okay. Uh-huh. True. Okay. Now, how I would consider that in a way, all right? So, firstly, yes, I would maybe consider where they're reading when they're outdoors in a way. So, even if they're reading like this is a bit more like it's not as frequent probably, but if they happen to maybe read like at a park bench, where they're like outside, and they happen to be reading, or maybe they're at the front at the front porch of the house, and they're just spending some time outdoors there. I do actually consider that outdoor time, but the thing is that is still considered near work in a way. Okay, yeah, so that's where you have to take that into account also. Now, when it comes to near work, there is a good rule of thumb where we do not want them to spend more than 2 hours of close-up work apart from school. Okay. Yeah. So of course they would have to do whatever schoolwork that they would have to do, and all the spend time in school is mostly close up. But for leisure time, they're playing games, and just maybe if they enjoy like reading a book or whatever that they do enjoy close up. Yeah, if it's less than 2 hours, generally it's considered pretty okay. So 2 hours is like the magic numbers. Every day you spend 2 hours outdoors, and every day you spend 2 hours, spend less than 2 hours on like close up stuff. Now, and so if let's say parents said that okay, so they generally in a day spend less than 2 hours outside after you take into account like recess, break in school, maybe going to school, coming back, and all that. And then if they also spend more than 2 hours on like leisure screen use, then you know that they probably, in terms of risk factors, probably a bit more higher risk in a way. That's for environmental risk factors. What about genetic risk factors? Okay, so that's the other thing we have to talk about also. All right. So we know that if they have two parents who have myopia, they would have higher risk of getting myopia also, compared to if they were to only have one parent has myopia, one who's not. And then also the one who has the least is the one who has no one in the family that has myopia at all. Okay? Now, when it comes to, there was a very interesting not really a debate but some sort of when, so I went to this conference, right? I think it was about, was either last year or the year before, where the speaker was basically saying, is it really genetic factors that causes myopia, or is it potentially because of their environmental factors in a way? So what he's trying to say is that, so mostly if let's say parents who are myopic, right, they maybe for instance do generally spend a bit more time indoors anyway, and maybe they do enforce education a bit more, and because of this it sounds like it's a genetic, but it might be more of an environmental factor that put the kid into that situation, and hence that's why they have that issue. And this is really interesting because when I think about myself, all right, so my mom and dad, both of them don't wear glasses. They are hyperopes. If anything, I think my dad is, he has a bit of astigmatism. Yeah, and so both of them do not wear glasses at all. But my elder sister, myself, and my younger brother, all three of us are like high myopes. Interesting, isn't it? Yeah. So like so my grandparents also, none of them wore glasses, Yeah, so none of my grandparents wore glasses for like distance vision. My mom and dad has like pretty much perfect vision, and I'm a high myope. You know, yeah. So I know for myself definitely like when I was growing up, I was playing a lot of online games and whatnot. I was also like do a lot of study after school. So I know that all of this definitely does play a part as to why I'm a high myope. So, which was very interesting because when the speaker mentioned that about maybe it's your environmental factors instead of your daily day to day that causes all of this, right? Like it really got me thinking, hey, actually, you know what? That might really be true. Okay, but of course, in terms of like what we're talking about, in terms of generally how people categorize like genetic factors about myopia, there's definitely a risk factor in a way. Okay, yeah. So I would say that those are like probably the important things to look at. And of course, the next thing would be also in terms of their ethnicity. Okay, this is a bit of a tricky one because generally, of course, we don't really say that. Oh, okay, so if a kid is of this ethnicity, then we might maybe manage myopia a bit differently than kids of a different ethnicity and whatnot. But it is definitely in the research study. Which one, like which ethnicity, to your knowledge, is the one that has the highest rate of progression? Yeah, that's right. Okay. To be very specific, is Asians in a way. Okay. Yeah. All right. So what's considered is Asian is actually like uh Chinese race or Korean, Japanese. All right. Yeah. So these are all like the very some sort typical East Asian races that has been found in the research that they actually do progress, their myopia do progress a bit more quicker. So anytime you do have these kids coming in, just be a bit more wary that there is a higher chance of their progression being a bit quicker. All right. So you might want to be a bit more aggressive in a way in terms of when you're managing their myopia so that you have the least chance of them just, suddenly their prescription just going up really quick. Okay. Yeah. So that being said, of course, when we look at different ethnicities apart from the Asian kids in a way, we should not think that like their myopia should be fine. They are not really progressing in a way because of course everyone progresses at a slightly different rate. Okay, so we just have to be a bit more aware of it. Okay, yeah. So I would say those are probably like the really main things that you might want to ask. Now, some like optional questions to ask are things like headaches. Okay, yeah, do they really experience any like asthenopia or like headaches and stuff? Because if you think about it, right, why do you think low myopes get headaches? Is there anything that why you can think of? Mm. Precisely, yeah. So they are squinting too hard. They're really trying to strain. So when they're really trying to focus, sometimes they do squint and sometimes they don't really squint, but they just like look far away and really try to like focus their eyes. And those are the times where actually what happened is that their eye muscle is just trying to focus harder. And then most of the time you realize that like they usually their myopia is about like either -1 or much lower. All right. Yeah. So these low myopes, they are the ones who usually would start to get headaches. Yeah. And that is also another sign. But I wouldn't say that it's across the board. Not every single kid will have that. So just take that with a bit more of like a pinch of salt in a way. Okay. Yeah. All right. Now, next come to the test that we want to perform in the room. Okay. What are some important tests that you can think of on the top of your head already? Yeah. Yep. Mm-hmm. Yes. Very important. Yeah. That would be great if yeah. Mm-hmm. Yeah. That's right. Yeah. Yeah. So BV workout is actually very important. Okay. I must say that so in terms of the test that you want to perform when it comes to binocular vision, it's not really every single thing under the whole plethora of like tests and whatnot, but two main ones that you might want to look a bit more into, especially for myopic kids. So lack of accommodation, and next thing is ACA ratio. So that's the accommodative convergence over accommodation, okay, or per amplitude of accommodation. Yeah. So with the lack of accommodation, we want to make sure that they're within that normal range of roughly about a plus 050 to a plus 1. Okay. Now, of course, it's better if they're like at that 075 is like I think the most Most kids would probably be there, but some might be a bit more or slightly a bit less. So that's what is a bit of the range. So 050 to like a +1. Now anything more than that, so like +1 to 5 plus 150, that is when I would probably say that because there has been studies that show that these kids who have higher lack of accommodation might tend to progress a bit more quicker. Okay, yeah, and also ACA ratio. Now, we're pretty lucky in a sense that when we're measuring ACA ratio, the easiest thing you can use is the flippers. Okay, so all right, so let's talk about flippers. All right, yeah. So this is the one that I would potentially use in a way, right? So these are like the plus minus 2 flippers, and this is the plus minus 1 flippers. Now this will make it very very easy. So what you want is to have the uh, yeah, to have this the Howell Dwyer cut. Okay, so I think what you did the other time when you were doing the test for me was good. So you did this because you know that's about 33 centimeters, and then okay, so you got them to hold it there, and then of course with the 6 base down prisms. Okay, so what you usually want to do, because you would have like the plus minus 2 with you, yeah, so you just put it on top of their eye, so +2 and then -2. Okay, and then of course allow them to be able to focus, and then you just ask them, okay, where is it really sitting at? Okay, so for instance, if let's say we do a +2, okay, so for instance, without anything, if I'm, let's say, a 2x of Fourier on the blue side, right, and then when I do this, okay, suddenly I'm like a let's say I'm a 14 over here. Okay, all right, yeah, so let's say it's 14 over there, and then when you do the +1, okay, let's say I'm some sort of like a 6 in a way. Okay, all right. So from there you can roughly tell that, okay, so without anything, I was like a 2, and then after it became a 6, all right, with the +1, but then suddenly it became a 14 with the +2. So if you take 14 minus 2, so that's about 12, and then if you divide by 2, that's about 6. Okay, 6 is very high. Okay, so generally a good rule of thumb, about 3 to 3.5 or above, that's where you would generally consider that their ACA ratio might be a bit on the high end. So easy say, like if you find that they're 4 or above, definitely know that they might have a higher risk of progressing myopia much quicker. This is also a very good test for those kids who are pre-myopic or very, very low myopia, like a -0.25 or -0.50. Yeah, so when you do this test, because um, it has been shown that for these kids especially, they might tend to be much more faster progressing myopes. Okay, yeah, so I would say those are like the main ones that we want to have a look at, right? But of course, the other BV test that we would do is like cover test, all right? So cover test is very important, and then you just want to check their Fouriers in a way. So using the Howell Dwyer cut is good. That's one way to do it. Or you can even do like the prism bar cover test. So that one is also fine. Let's see, yeah, and then of course you want to check their motility, just making sure there's no yeah, that their eyes are moving fine. Pupil assessment, of course, that's very important. Yeah, so I think those are like the main tests that you definitely want to perform on a child in a way. Okay, yeah, so when they come in, the other two, which is also color vision and stereo, that's just more of like general tests that you want to perform, right? Yeah, so that's also very important for them. What else from there? What else can we think of? Um, yeah, I think those are probably the main ones when it comes to to like the pre-testing in a way. Now let's talk about how you're gonna measure them up in terms of, you know, whether you want to use like a trial frame, or would you want to use like a refractor head or a phoropter. Like, what's your thoughts on it? Mm. Mm-hmm. Mm-hmm. It is. Mhm. That's right. Yeah. So generally, with most older kids, I would say after the age of 8, usually, or some of them are pretty good, like even 6 and above. The refractor head or the frog is actually pretty good because they can actually listen to instructions. They understand what they need to do. With the much younger kids, I would say 6 and below, generally, I would actually use the trial frame for them, because firstly, it's really hard. Like they might, not really get behind the phoropter as well, so it might be a bit harder. Yeah, so just take note. So 6 and below, generally I'll do trial frame, and then 7 and above, I'll use the phoropter, because usually they understand a bit more already. And then what you want to try to do, especially if they're like first time myopes, right? Always try to push for the plus in a way. So I don't think there's anything wrong with pushing for plus, especially for like first time myopes, because it's their first time with glasses. Anything that you give them is going to be better than not having glasses at all. Okay. Yeah. So with first time myopes, I generally, yes. So you still want to correct them fully. Make sure that individually each eye, they can still read 6/6. That's very important. Okay. Because we know that under correction does tend to progress myopia even quicker. So we do not want to do, under prescribing. What under progression am I talking about? Yeah, so under prescribing, if you don't prescribe them the right amount of prescription that they need in order to see 6/6 individually each eye, they're going to progress much quicker. So never under prescribe your patients. Okay, yeah. So yes, so pushing plus is important, especially for like first time myopes. Now, how about those myopes who are coming back for their checkups? Like, how are you going to tweak the testing in a way? Yeah, when you're doing the refraction itself, yeah, how are you going to tweak it? Okay, so generally, what I like to start with their habitual prescription. Okay, yeah, so that's right, yeah. So always start off with what they have, because if let's say with their current prescription, like they're already reading like 6/6 on their right eye, or reading 6/6 on their left eye, then you know that generally their vision is not really changing much. Yeah, and also that's how you're able to tell if they are progressing. If you find that with their current prescription, they're already like with maybe the right eye, they're reading 6/12, and in the left eye, they're reading like 6/9. So you know that in this case, maybe there's about a 0.75 to 1 diopter progression in the right eye, and about a 0.50 to 0.75 myopic progression in the left eye. So this is how you like kind of tell, whether they are really progressing or whether they are not really progressing as much in a way. The current prescription they have is a very good indication, especially if they've not been to your practice before and you do not have an indication of what their previous prescription was. So if they come in and then like okay, so they already have the current glasses with them, I would definitely use that as a baseline, and then we can compare it to whatever you found on the testing day itself. Okay, yeah. So as we can tell that like in terms of myopia progression, we definitely want to look at the prescription also, because that's what the patient is seeing. Yeah, and hence that's why whether they are using glasses or MiSight contact lenses or ortho K, or even like just normal atropine drops, right? Yeah, so these are all like the four main options that we do have like available, and you do want to make sure that whichever options that they're on, we do find a way to measure their myopia progression if there is any. Okay, yeah. So that's the in terms of refraction. Yeah, so you do the spherical bit and then you check for the astigmatism, and then from there, then you can see if there's any much progression. Okay, so what's next after refraction?
What's next?
Yeah.
Check
Yeah.
eye health.
Eye health, yes, that's right. Okay, yeah. So because in the initial part of it, you have already done like the pre-assessment in a way where we've already checked like their binocular vision and all those other stuff, and then we check their refraction. So now we go into the eye health. Why is it important to check eye health in myopia?
Well, like high myopes are more prone to getting tears or irregular attachments, stuff like that. So it's just thinner because it's much longer, the eyeball. So just checking for that, making sure everything's all good.
Yeah, precisely. Okay. Yeah. So especially with the younger myopes, like you just want to make sure that when they are, well, sorry, not with the really younger ones, but with those who are maybe a bit older or have been wearing glasses for quite a while now, for at least a few years, we just want to make sure that eye health is fine, eye health is healthy. With higher myopes, anything I would say like -6 and above, Generally you just want to make sure that their peripheral retina, that everything is nice and healthy, okay? Because we know that the higher the myopia is, like what you mentioned, there's more stretching that's done on the retina itself. So the more the retina stretches, the more there's a chance for there to be like breaks and there to be tears and all those other kind of things. What are some common eye conditions that we want to look out for, or that we want to make sure that it doesn't that so okay, so someone who has myopia, what are some eye conditions that they might get in the future because due to high myopia? Mm. Glaucoma, that's right, that's one of it. Okay. Yeah. Cataracts, yes. Uh-huh. Two more. Yeah. Okay, so yeah, so glaucoma is one of it, and then cataracts is the other one. Myopic maculopathy. All right, yeah. So let's not forget about that. That's where basically the macula itself. Yeah, that's the because of the retinal changes, right? Their vision might drop. So you might not really find things like maybe drusen, like AMD kind of like changes, but you might find that on the macular area itself, you start to get some atrophy on it. And then on top of that, also their VA itself will drop. So maybe from 6.6, they maybe become a 6.7.5, or maybe potentially even a 6.9. This is like for really high myopes in a way. So we don't want them to be able to get there. Okay, and the last one is actually the one that you mentioned before already, which is retinal detachment. Yeah, okay. Yeah, so retinal detachment, retinal tears, all these different kind of things. With high myopia, or generally with myopia itself, there's much higher risk for it. Okay? Yeah, so we just want to take note of those few things. Okay. Yeah, so when we're checking their eye, especially for higher myopes, you might get what's called like a crack appearance at the back of their eye. It's also called a tigroid fundus. Okay, so they have different names for it, but leca crack appearance or tigroid fundus is pretty much the same thing, right? And yes, typically it is in higher myopes, but even in lower myopes, sometimes you might find it also. Okay, yeah. So just take note of those few things. And then what's the other thing in terms of the anterior eye that we want to check just in case also? Mm. So let's say they have myopia and they have astigmatism. What do we want to check for? Yes, that's right. Okay. Yeah. So of course, it depends on the practice that you're at. Not all practices have topography, but even if you do not have it, it's a good idea to just pick up your retinoscopy. All right. Your retinoscope. I don't know why is it hard for me to say, but yeah. So yeah. So because you just want to check that there's no like scissors reflex and things like that. Because if let's say they have like high astigmatism also, we just want to make sure that they do not have like keratoconus or any corneal conditions that might actually impact their vision, and it might not actually be true myopia. Yes, it's a bit lesser risk that this is happening, but we cannot say that it would not ever happen. Okay, yeah, so we must know that, especially if they have like a high amount of astigmatism. I would say generally like 150 or anything that's above that, I would definitely just double check to make sure that there isn't any keratoconus that's in play, apart from the myopic progression that we do expect from them. Okay, yeah. So topography is one thing that we can check with. The retinoscope is the other thing that we can check with. Is there anything else that you think we can? Yeah, that's right. Or maybe have some sort of an indication. Yeah. Mm. Mm-hmm. Yep. Mm. Mm. Yeah. So slit lamp is pretty good, but sometimes it is a bit hard to tell if there's really any thinning on it. Now with the auto refraction results that we get also, that's another really good one. Okay. So just because with that you can actually look at the K values, and if let's say the K value is super duper steep, okay, then you might say, hey, this actually seems a bit yeah, it's a bit abnormal. It's not what you would usually see. And when that happens, then it might trigger in you, hey, maybe I just want to check if the patient does have any keratoconus. So it's very important for us to detect it early, because the earlier we detect it, the more that we can do for them. And we know that with keratoconus, what is the one condition, what is a surgery that they can perform in order to slow it down a bit? Yeah, yeah. So,
Using
uh-huh.
the light to strengthen
Yeah.
that. I can't remember the name of it.
Yeah, okay. Collagen
Yeah,
cross-linking. Okay.
cross-linking,
Yeah,
that's it.
so they can
Yes.
get cross-linking done in a way. So I can't recall the exact intricacies of the surgery itself, but yeah, I think it's like UV light, with riboflavin or something onto the cornea itself, which is meant to like really strengthen the collagen fibrils so that it doesn't get like worse over time. Yeah. Yeah, but let's talk about more about that normal myopia. So those are the things that you really want to look out for. When is it a red flag for you that you should maybe potentially refer your patient off to see a specialist apart from like keratoconus issues? Yeah.
What is it, red flag?
Mm.
I guess unexplained vision loss.
Yeah. So when you say unexplained vision loss, so
Like
that's a drop in the
drop
visual
in vision,
acuity,
yeah.
is it?
And we've
Yeah.
done like slit lamp, we've done
Mm-hmm.
refraction. There's just no
Yeah.
explanation for it.
Good.
Then
Yep.
I'll refer them.
Mm-hmm.
I'm not sure if like you see a huge progression.
Mm-hmm.
I don't know at what number you
Yeah.
refer them. Is if that's a thing. I'm not
Yeah.
sure.
So in terms of this is a very good question
Yeah.
actually, that you have about that. So how much progression is considered like normal and what's like abnormal in a way, right? Yeah. So yes, most of the time if we see like an 025 or 050 progression in their vision, we wouldn't really. Yes, we know that there's myopia progression. We can potentially manage it.
Yeah.
Yeah, but what if we see something a bit more? What if it's a -1? What is a -150? Like, where is the upper limit that we
Yeah.
want to refer them off in a way? There's actually no right answer for it, to be honest.
Okay.
Yeah, so it's really hard for us to say,
Yeah.
okay, when it hits this much, then refer them off. But what we can do is that to actually look at their current level of myopia, right, and just see where they are really sitting at the moment. So for instance, if they are like maybe a 6-year old, all right, and they're like already like a -6, or maybe they're a 10-year old but already a super high myope for what their age is, yes, that's when you probably want to refer them off, because you just want to make sure that they don't have any genetic conditions that are coming into play. So some of these conditions we know might be like Marfan syndrome. Okay, yeah, because we know that with but of course with Marfan syndrome, there's much more than just myopia that comes into play. Like even their eyes itself, they might have really long arms and whatnot. So there's definitely a couple of like genetic conditions that can be the result of high myopia. Yeah, and you just want to make sure that like if they are really young and you know that generally kids of this age should not be of this prescription, but they are just way above that, just refer them off for a second opinion. Now, the other thing that I would also consider is that maybe trying to ask them, the kids or the parents, like, when was this vision change noted? Like, was the huge change? So, for instance, if you find like a -150 change, but they said that, hey, it's probably only been like in the past couple months that they've got this. What should be, what should be, what should you be thinking of now? If let's say someone is like a -1 change in like a 2 months period,
like
probably.
really fast progression.
Yeah, like
Yeah.
super fast.
Yeah.
Yeah.
But yeah, I don't know what to
So
go on from there.
yeah, so I would say if let's say you check their eyes itself,
Yeah.
everything looks normal, right? Refer them off to their GP to check for diabetes.
Oh,
Yeah, so
okay.
this actually happened to a colleague of mine before. So I think it was a 10-year-old kid coming in. And then so his vision initially was like, okay, so he was like plain, had no prescription before. And then the time when my colleague saw him, he was sitting at like a -1 or -125. So you would think, oh, just normal myopia in a way, isn't it? Yeah. But totally missed the fact that he's actually type 1 diabetic. Yeah, so and so when he was referred off, I went to the GP just to check, like, to see what's happening. They realized that he was type 1. Yeah, and that's when they were asking, hey, so this change in the vision, like how fast was it? And literally it was just within like a couple of weeks or like a month or two in a way. So sometimes you will get like, because of the change in the blood sugar, That's why it seems as if they become myopic in a way, but they might not be. Yeah, another case, I had this, I think about 2 weeks ago. This lady is much older. She's already in her like in her 40s, I think early 40s. Yeah, so her myopia in a year just went up by like -1. And I'm like, so she's been stable for a long time. She said like it's been more than 20 years. Yeah. Did, were you sitting in with me? I don't think so. Yeah, okay, yeah. Yeah, so I was like, this is really odd. Like, why is she progressing suddenly after 20 years of like a fairly stable prescription? So when I asked her like just this one question, is there any family history of diabetes? She looked at me for a good 5 seconds and she was like, yes, and she's like, my mom is diabetic, my sister is diabetic, but I've never been diagnosed. So I told her, look, I'm not saying you have it, but I think it's a good idea if we refer you off and just have a general checkup with your GP just to make sure that your blood sugar, everything is fine. Because if let's say that all is fine, then we know that it's truly myopic progression. We'll just do an update for the glasses, maybe talk a bit about myopia management and whatnot, and that's done. But let's say if it's diabetes, then that's a whole different thing. Okay, yeah. So always think about it in those things also. If it's really young but super high myopia, think about genetic disorders, which is a bit more rare, but it can happen. But if it's a sudden change in the vision in a short period of time, yes, it might be myopia, but it might be something else also like diabetes. Okay, yeah. So you just want to make sure. Okay, yeah. So from all these different things that you have got in a way, this is how you can pretty much categorize patient into like low risk, medium risk, or like high risk in a way. Yeah, yeah. So now, someone who's low risk, might be maybe like a pre-myope. So pre-myopes are hard for us to really tell like what they should be in a way, but but with the pre-myopes, this is where it gets really tricky to like, do you want to manage them or do you want to watch and wait and see how things go? So what you want to do in terms of that is that you really have to see in terms of their family history, in terms of their environment. Is there anything that might cause these low myopes to really, or at least low myopes or pre-myopes to really accelerate? So let's say if they have like high ACA ratio, they have like lack of accommodation, but like everything else seems fine. Yeah, so this is where I would say that generally talking about like having good environmental influences is actually much more important in the sense that spend more time outdoors. Just go out, just like spend time outdoors, especially on the that can help patient in terms of like myopia and all this stuff. Yeah, yeah. So screen time, we want them to reduce the screen time. Okay. Taking breaks, very important. Okay, yeah, that's right. Yeah, so this is a very interesting one. Okay, the 20-20-20 rule, right? Yeah, so the 20-20-20 rule states that for every 20 minutes of close up work, take 20 seconds to look about like 20 feet or basically 6 meters away. Now, there has actually been a research study that has been done to show that it's actually effective for two different conditions. Okay, so number one, for someone who suffers from digital eye strain, so if they look at screens for a long time, and then that can actually help too because they're breaking the accommodation cycle, right? So that they will get less of that. And the second one is actually mild dry eye disease. Okay, so if someone has really like mild dry eyes in a way, just and we know that usually it is because of them spending a lot of time in front of screens, apart from using eye drops and all this fancy stuff. Yes, if they do take those breaks, it actually does help out. Now, but however, in terms of myopia progression, there's actually there's actually a thought behind it of that the 20-20-20 rule might not be the most effective because basically you want to have a sustained break. You want the eyes to relax long enough. If it's relaxing just for 20 seconds every 20 minutes, it might not be enough for the eye muscles to really relax. So in fact, what would be better is actually a 5 minutes break every hour. Yeah. So even with a lot of my older, I mean, I wouldn't say really say older, but those who are maybe were in the early 20s or maybe even patients who are in universities at the moment, it's really going to be hard for them to take a break every 20 minutes most of the time because they have to be like on screens quite a bit. Or if they're working, it's really going to be hard to like 20 minutes and then, like look away, 20 minutes, look away. Yeah.
Watching the flow state
Yeah.
as
And
well.
most, yeah, precisely. Yeah. Like they're in that nice flow, they're doing work. Yeah. So I do find that when I tell them, look, try this out 5 minutes every hour, it is way easier for them. Like if you think about it, like for me and you also, right? Yeah, like we know that 20 minutes block is really short, but when you are given an hour block to like do something, and then like what I usually tell my patients, you might maybe have heard me saying this also, which is, hey, you can just try to take like an hour break every 5 minutes, and for the 5 minutes, you can either like walk around, you can either close your eyes, just try not to focus on doing close-up work. Okay, yeah, and as long as you're not doing that, it should help to really relax the eye muscles a bit more. Yeah. So those are actually very important things for us to look at also, especially for the low myopes, because we want to be able to help them out, and environmental factors, things that they can do, you want to be able to help them out with that also. Okay. But of course, when it comes to close-up work, the other thing to consider also is the distance. Okay. Yeah. So we don't want them to be holding things like this close, right? Right? The other way that they can do it is actually, so it's called the elbow method. Have you heard of it before? No? Okay. So usually what you do, a fist, chin, here, and then here. So that's roughly how far they should be holding things. It's pretty cool, isn't it? Yeah. Yeah. That's right. Yeah. There's actually a name for it. So I'm not the first person to think of that. I'm not going to take credit for it. There's actually someone who came up with this like distance rule term thing. Yeah, but I just call it like the elbow method because it's easy. Just fist to chin out, and then they can roughly know. Okay, that's roughly how far they should be holding things, right? Yeah. So yeah, so those are like for the low myopes in a way where maybe they have like maybe not much even family history of myopia and everything's pretty good on that end. Now let's talk about those who like in the mid or medium risk of progression. So these are probably those of them who already maybe have a bit of myopia already. Yeah. So and they are progressing either by genetic factors or by environmental factors. Okay, but their myopia is not like super high. So maybe they're sitting at like the -1 to the -3s in a way. So it's not like super duper high, but it's still progressing. But let's say they don't have any of the other signs, like their BV is normal, ACA is normal, no lack of accommodation, right? Yeah. So how would you usually want to manage these patients?
Making
Yeah.
sure they're fully corrected.
Yes. Yeah.
And
Mm.
then I don't know if you depends on if they're
Mm.
progressing. Are they
Yeah.
progressing a lot?
That's right, yeah.
Or
So it depends whether
yeah,
they're progressing a lot or not. But
yeah,
in this case, they might not be. So they might be maybe in a year progressing maybe just by like an 025 or maybe maximum an 050. But then again, like yeah, there isn't anything else. There's no like genetic factors, environmental factors. There's no other factors that show that they might progress even more. Usually with this kind of patients, I'm usually pretty happy to keep them on the current option that they're on already. So if they're using Alt-K or they're using MySight or if they're using the uh, myopia control glasses or even the HP drops, I'm happy for them to stick to what they're currently using. If their vision starts to get that they can't read 6.6 comfortably, usually that would be an 050 change or more, then it's probably worthwhile for us to update whatever option that they are currently using. Okay, you would be surprised because even with an 050 change, most kids are actually going to be finding it like their vision is still fine because again kids are not so fussy. Like a bit of blur like for most of them is still pretty okay. So you just want to make sure that when you test them in the testing room that you're not getting anything more than that 050. 075, there's no two ways around it. I'm definitely going to be updating their prescription for them. Yeah, but that's why there's a bit of a there's probably a bit of a leeway, especially with 025 script changes. I wouldn't really say that it's a must change for them. For 050, they will realize the benefit already, so which is good. Okay, yeah. So usually those in the low and medium risk, you will be able to manage them. Okay, because like their myopia is not progressing too quickly and whatnot. How about the high risk group? Okay, so these are the ones that are probably progressing by 050 or 075 within a year. and they're probably a bit more younger also. So maybe they're less than 12, or they might be like 13 years old. So they're still within the age where their eyes are still growing in a way. And then maybe they do have environmental factors also. Mom and dad both wear glasses, okay? They're really spending a lot of time on screens, okay? How are we going to manage these guys?
So definitely looking at like
Mm.
more control options.
Yeah, uh-huh, yeah.
For me personally, I haven't really delved into like
Yeah.
okay or glasses,
Mm.
so I'd be more comfortable with atropine.
Mm-hmm.
Um, so yeah, so looking at those options, seeing what they like, because atropine, they might not like light sensitivity. So,
That's right.
and all like glasses might be too expensive. You just gotta factor all that in as well.
Yes.
But yeah, and then monitoring with the checking out to
Mm. Very important. Yeah.
Mhm.
So usually with those who really progress really, really quickly,
Yeah.
I am actually very inclined to firstly see what option that they're currently on.
Yeah.
So number one, if they're not on any of the options, it's time to really get them on it. So just present the fact, look, the myopia progression is really, really quick. Let's do something about it.
Yeah.
Okay. Yeah, we don't want to just be sitting on it and not do anything because it can get even worse over time. And when you are going to be talking about the uh, sorry, in terms of the different options that we do have, I would say that usually we want to have an option that is able to consistently help them out. And usually for the high risk group, dual therapy is what would be recommended in a way. Okay. So of course, there's nothing wrong with maybe just trying out on the one and then see how it progresses or not progress. Yeah, but dual therapy might be a better option. So one method of dual therapy that is already research based is ortho-K plus low dose atropine, in particular plus 0.01% atropine with ortho-K has been shown to be much more effective than just either ortho-K or atropine on its own. Okay, so that's one method that I do actually talk to parents about, especially if their kids are really progressing really quickly. And one of the reasons why ortho-K is kind of a preferred method over the other treatment options, right, is because of the constant peripheral defocus that their eyes get in a way. So as soon as like they wake up in the morning, they take off their lenses, they get that peripheral defocus there all the way until like nighttime, and then like so it's always there. Okay, but of course there are some still valid options like MiSight contact lenses and also the myopia control glasses, but we just have to make sure that they are fitted well with it, especially the glasses. Okay, now what happens if they are not fitted well?
They'll be looking through
Mm-hmm.
the defocus area.
That's right. So number one, they'll be looking through the defocus area. Yeah. And they will feel that it's not clear. Secondly, they're not getting that myopia control effect that we wanted. Okay. So if they're not getting the myopia control effect, then it's going to be a bit counterintuitive in a way, where it's not really helping them. It's not really helping their vision also, and then their myopia still progresses. So that's why the importance of like fitting kids who are either on like the MyoSmart Stellus lens, or Zeiss actually have a lens called MyoCare, which they also have come up with not too long ago. So all these three are very valid options for myopia control, and we just want to make sure, yeah, that like if they get on any of these glasses, that they are fitted well for it. Okay, so myopia control glasses. So for instance, like the MyoSmart lens, the fitting requirement is that they have to have at least 12 millimeters of like clearance above the pupil and 13 millimeters below the pupil. So pretty much like round Harry Potter glasses, if you think about it. Okay. Yeah. So that's how I kind of like try to remember in a way, like, okay, how are we gonna fit all these different kits with the different lenses and whatnot? Okay. Yeah. So yeah, so those are things that you just want to make sure that, especially for kids who are progressing, that we want to help them out in a way. Now, of course, we can get really complex as to like what kind of cases that we're going to be seeing and whatnot. Yeah, so just take note that either they are low risk, medium risk, or high risk. You can manage them. Okay, the only ones that is considered to worth referring is any one of them that has any pathology behind it that you might be suspecting, like the ones we talked before. Keratoconus is one of the biggest one, and then of course any of the genetic conditions that they might have, like Marfan syndrome. Yeah, we just want to make sure that if it's like high myopia, especially for their age, refer them off just to get them checked. And let's not forget about the super quick increase in like a matter of a few weeks or a month, diabetes. Okay, let's not forget about that. Refer them off to the GP just to get checked and all that. Okay, yeah. So those are basically like the main way of how you want to assess and how you want to briefly manage the myopia. Okay, yeah. Is there any particular thing that you might want to maybe ask a bit more about any of those things that we've mentioned? Yeah.
I guess at what amount of progression are you like, we should start now?
Okay. All right. So, in fact, the first sign of myopia. Let's go.
Oh, just
Yeah.
just when they first.
That's right. Yeah. Okay. And of course, this is personally how I feel about it. Yeah. Okay. So if you look at any other eye conditions like glaucoma, all right, or like if someone has I think glaucoma is a really good one because like when you see someone has the first sign of glaucoma, you don't wait to see how they progress, like how bad it gets before you start treatment. You usually want to start treatment straight away to try to either like lower the eye pressure, or find one way or another so that it doesn't get worse over time. So it's the same thing with our prescription also. Why is it such that like if someone's a minus 050, we don't manage them until they get like to a minus 150? Yeah, like why? Yeah, I mean, yes, we do understand that someone who's like a minus 050, maybe might not find things as blurry, but someone who's a minus 150 will. Yeah. So usually for me, on the first onset of like if they have myopia already, then I would want to manage them. So generally, anyone who's 075 and above. Why do I say 075 and above? So sometimes you do get pseudomyopes coming in, all right? Yeah, so they might be like an minus 0.25, but like generally they're still seeing 6.6, they're still seeing nice and well, but maybe it's a bit of like accommodation issues that they're having. So usually I find those who are like the minus 0.25 or maybe a bit minus 0.50 also, most of them might not really be like true myopes, although some of them might be. Now, when you talk about the minus 0.75 and above, they potentially have true myopia. Okay, yeah. So that's where, so you would want to see if they're minus 0.25 and minus 0.50. If they're true myopes, of course, start them on straight away. So cyclo, that's one of the best way to really figure out, yeah, if like they're really if they really have myopia, or is it just pseudo myopia. Yeah, but those 0.75 and above, usually they are true myopes, and you just want to start them off already. Okay. Yeah, but even if someone's a low myope, like a minus 0.50, which because I had that just a week ago. I'm not sure. Did you sit in with me for that patient? So the brother is like did ortho K with us, um, and then okay, so maybe you did not sit in for that one. So just to share, the older brother did ortho K with me about 4 years ago, because his myopia was, I think, was about a -2 or -3 thereabouts. So we did ortho K on him, and thankfully, past 4 years, no progression at all. But the older brother. So the older brother now is 13 years old. He's 12 years old now. Okay, so he's good. No myopic increase. His brother now on his right eye, if I recall, is a minus 0.50. This is true myopia, minus 0.50 on the right eye, but it's actually a plus 0.50 on the left eye. Initially, they came in because they wanted to do ortho K. Yeah. Now, because of the low amount of prescription, it might not be as worth doing ortho K. Yeah. So with the minus of 50, but I recommended them using the MySight contact lenses. Yeah. So you see how yes, they have started to show signs of myopia, and this is true myopia. It's not like a pseudo myopia thing. So that's why even as low as 0.50, I start treatment straight away. Yeah, because I find that they are going to benefit from it. And because so both mom and dad is a myope, both of them do wear glasses, and the younger brother who we've done ortho K for, of course, he's a myope also. So why are we suspecting that he might be any different? Okay, yeah. So this is where we did MySight just on his one eye, and then I said, look, let's monitor in 3 months' time and see how things go. Yeah, so it can be as simple as that. Okay, yeah. So that's where you would want to start them off as quickly as possible at the first sign of true myopia, that's when you want to just start treatment already. Mm, yeah. Yep. So I think that's a really good one. Let's see. Anything else that might be on your mind? Yeah.
I think I know there's like different levels of myopic maculopathy.
Yes.
At that like severe stage, what can be done?
Nothing.
Anything.
Unfortunately, no. Yeah.
Okay.
So this is the unfortunate thing about maculopathies in a way.
Yeah.
It's a bit irreversible, just like how glaucoma is. Once they get it, they can't really reverse it back. And that's the reason why it's so important for us to manage low levels of myopia for it to not become super high. Yeah, because like once their vision start to get worse, once you start to see atrophy on the macula itself, there's generally nothing much that you can do. So, for instance, we know that with like AMD, right, with age-related macular degeneration, if it's a dry kind, there's also nothing that you can do about it, which is pretty sad. But usually, those who have dry AMD, the vision is not too bad. It doesn't progress as much. But those who have wet AMD, yes, something can be done about it. Mostly myopic maculopathy, especially if there's not any kind of fluid that's involved, there's really nothing much that you can do about it. Yeah. And hence that's why like it's so important to treat or start myopia management as young as possible. So the younger the kid is and they show signs of myopia, let's get them on it. Yeah, as soon as possible. Yeah. And I would say that yes, measuring axial length, like the machine that we have here, is going to be great because that really shows true progression. And we know that accommodation is not in play when we're measuring the length of the eye. Yeah, but even if you do not have that machine in the practice that you might be working in the future, just track the myopic progression itself and always do that. So without the glass, sorry, with the habitual glasses, see what the vision is. Yeah, and then of course when you refract them, you see what the difference is then, and then you can prescribe from there. Okay. Yeah.
Another question.
Yeah, yeah, yeah.
So say a patient's on ortho-K, like that child, he was on it for 4 years.
Yes.
He's not progressed yet. At what point are you like, yeah, I think we can stop, or are you gonna?
Yeah. Now, this is also a very good question when it comes to like when do we start myopia management? Yeah. So there's actually not really a a time where we want to stop in a sense that if they're still young, all right, and generally, yes, the main idea of myopia progression is so that their eyes don't get worse over time. If the treatment is still working, we do want to keep them on it as long as possible. So, for instance, even with ortho-K, all right, yeah. So yes, we do recommend every 2 years to change the lenses itself, because what happens after 2 years is that the lens integrity, it might not be as good as it was when they first get it. So environmental factors, changing the lens and all this sort of stuff. But the idea behind it is that we know that as they grow older, they are going to be in school. So they're going to be in high school, and then after that, they're going to go into university. So there's just going to be a lot of things that they really require that huge visual demand in a way. Generally, we would say till their late teens. But if let's say they are going to be going into like university and whatnot, just monitor them for a bit longer. And let's say if they are doing a lot of close-up work, but it's not really progressing as much, then yes, potentially we can stop those treatment. Usually, the question of stopping the treatment comes most of the time with atropine. All right, with either glasses options or contact lenses option, I rarely get parents asking, "Oh, when can they stop doing it?" And why do you think is the reason? Yeah. Yeah, but also because the kids are currently using those treatment options, right? And it's working well, and it's a visual treatment option, which means that like ortho-K, the kid is probably now used to sleeping in their lenses anyway. And they don't really find the fact that like, hey, if myopia is not progressing, and I like the fact that I don't need to wear glasses or contact lenses daytime, why should I change it? So most of the time, the kids don't really want to change, especially after they grow a bit older. Yeah, the only thing that they might want to consider, same with the other guys, is probably doing like LASIK surgery.
Right.
Yeah, okay.
Mm.
So yes, potentially if they want to do LASIK surgery or they do not want the current option that they're on anymore, then we can stop it. Same thing with the MySight, same thing with the myopia control glasses also. Because all of these different options, right? They are currently seeing well in them. And
Yeah.
if they are not progressing and it's working, why stop?
Mm.
Yeah. Atropine is the only one where, because it's not a visual treatment option, is the one that, they have to put it into their eyes every single
Yeah.
night. Parents and also kids can get quite sick of it.
Yeah.
Yeah, and usually they do want to be off it as soon as they can.
Mm.
So yes, for instance, with atropine, we have to do a tapering for it.
Mm.
Okay? So for instance, if we start someone, let's say with one of the highest dose that we know that is effective, so 0.05%, what we might potentially want to do, of course, there's no like true like guideline as to how we should taper it, but taper it in a way about, if you think about tapering steroids, but just over a longer period of time. Okay. Yeah, so when you want to reduce the atropine, so for instance, maybe from 0.05%, let's bring it down to 0.025%, maybe for another 3 months. Okay, everything's looking good. Okay, let's drop it down even more now to 0.01%. Okay, everything's looking good. All right, so now that it's been about 6 months, 0.01%, it's going pretty well.
Yeah.
Now let's, instead of doing it every night, let's do it every other night. So they're gonna be doing it about 3 or 4 times a week, okay, for another 3 months. And then what you can do from there is that yes, you can drop it even more. So instead of doing it every 2 days, let's drop it down to using it probably just twice a week, yeah, and then once a week, and then done. Yeah. So as you can tell with atropine, it is a bit more tricky in a sense that you do want to monitor it a bit better. And most of the time in actual practice, we don't really get it. We don't really get to taper it as nicely as that. Okay. And I'm not saying that everyone has to wait 3 months, 3 months, 3 months. Some practitioners might be comfortable like, oh, let's go for it for a month and then see if anything changes. So that's why there's not really a hard and fast rule on how you should taper atropine. Just like how when you prescribe steroids to your patient for whatever eye condition they have and you have to taper it down, yes, there's a general rule of thumb as to how long it should be tapered down, but the main idea is the tapering down of the dose of those particular options in a way. Okay, yeah, so definitely, I would say most of the time it sadly does come down to cost factors as to why maybe someone might want to get off myopia control treatment. Yeah, but we always have to kind of like remind them, hey, this treatment is currently working for you. So if it's working, we might not really want to risk it in a way. Yeah, and if let's say we do want to go back to maybe normal glasses or normal contact lenses and things like that, we just want to be a bit more wary of it. Okay, yeah, so those are things, important things. Mm, yeah. So I would say that that was actually a pretty good overview of like the assessment itself, how we want to kind of like manage the patients and whatnot. But of course, when you run into practice, it's not going to be as simple as that. Again, like you will find that there are going to be more complexities in terms of the cases that you have. But always go back to basics. So number one is that how are you going to correct their vision? And what methods parents and the kids themselves, what are they comfortable with? Like there's no point trying to push for ortho-K on MySight on a kid or also parents who are not keen on the kids using contact lenses for whatever reasons. Okay, yeah, so that's why the thing that we have went through for today will give you a very good overview. Yeah, but of course anything when it comes to specifics, it can definitely change with time. Okay, yeah, there we go. Okay, so yeah, so of course, if you, I know that like in a way like today's the last day for your placement and whatnot, but yeah, feel free to like keep in touch and whatnot. I'll be more than happy to like help you out here and there if you do have like any specific questions in a way. Okay.